Welcome, everybody, to our second in a series of two short webinars from the Big Sky Care Connect Statewide Health Information Exchange. We're excited about today's presentation. We have three guests with us to help us understand what the Health Information Exchange truly brings to a state who has implemented and matured their system. And we also have some guests to talk about what the technology will actually look like from the user end experience. Kelly is going to be working behind the scenes on our team to monitor chat and answer questions or stop us to answer your questions as we go through today's presentation. Our agenda today looks like this. We're going to start with a quick interview with Dr. Ann Polich, who is the Vice President of Quality and Performance Improvement at Methodist Health Systems in Omaha, Nebraska. And of note, their Health Information Exchange does utilize the same technology that Montana's Health Information will be utilizing. Following her presentation, we'll have a brief Q&A for Dr. Polich, as she's got to jump off a little early. And then we're going to be getting a demonstration from Chip Gore, Senior Sales Engineer at Intersystems. That is the technology that will be running the Montana Health Information Exchange, followed by a demonstration from Rachel Lieber, General Manager at Collective Medical, around the collective medical technologies that will be utilized for our alerting pieces. We will conclude today with a quick Q&A, and we'll be moving forward from them. Just a reminder, today's webinar is being recorded. We will have today's webinar and the webinar that we conducted last week available and sent out to all of you shortly after today's session. So I'm just going to go ahead and get started before we jump right into the questions with Dr. Polich. Quick introduction. Dr. Polich is, like I said, the Vice President of Quality and Performance Improvement with Methodist Health Systems in Omaha, Nebraska. She currently oversees the Methodist Health Systems Quality Risk, Lean, and Population Health departments, as well as episode-based payment initiatives. Prior to her tenure at Methodist Health Systems, Dr. Polich spent 10 years with the Nebraska Western Iowa VA healthcare system and has also worked as a primary care physician in Kansas. Dr. Polich graduated from the University of Kansas School of Medicine and completed her residence training in internal medicine at Creighton University. She served as the Southwest Medical Director for the KU School of Medicine and has led quality initiatives at the VA in Nebraska. Dr. Polich has served on the Blue Cross Blue Shield of Nebraska Quality Board, the Nebraska Hospital Association, and the Coalition Prescription Board. So Dr. Polich, with that, welcome. Thank you for participating today. Anything I missed on our introduction?
All right, thank you very much. So I'm here today to really discuss with you briefly about Nebraska's Health Information Initiative and how we've moved forward over the years, and really to share with you, I think, some of our best practices and also take questions today. So in 2017, really just a few years ago now, we were more or less transactional HIE. Mostly our emergency room physicians and our case management folks use the query exchange and the Pdmp. So fairly limited use, but really got our feet wet and developed super users around that as well. We were able to build a few ad hoc reports, but that really was not the main focus back then. And so, the opportunity really at that time we felt was in front of us, and we could either remain transactional or we could really transition to population health enablers, where we could really build a significant and extensive database that would really support both clinicians and patients. So by 2020, we are really population focused at this time. We still continue with the Pdmp, and that's been very helpful to reduce opioids and interactions of medications. because we do have all of the patient's medications on the Pdmp as well. But really, we have turned into Ncqa e-measure certifications, QCDR, a qualified entity, and so the HIE is really there to support healthcare systems in their need to submit data to mainly governmental entities. Value-based care is all we work with the ACOs, and that's also been a significant use of our HIE as well. So, what if we don't really use the information or invest in the infrastructure? What's the harm of not really moving forward? Can you really do population health without it? Not really. I like to think of it that everyone has a different focus. If you are in the EMR, you're getting current, good patient level data in the EMR, and you may be able to get some patient data that's outside of your system based on pre-existing agreements, but really you do not get a 360 of the patient. If you're at the ACO level, you certainly get claims-based data, but that's very much in arrears, and it's a very narrow focus. So, I think the only place to really get the complete look of the patient is in the HIE and as well as the health of populations. So risk-bearing contracts, as you know, each insurer really wants, as well as CMS, that you are risk-bearing with them as well, and that's difficult to do without knowing all the places that your patients have been. And then, of course, regulatory realities and conditions of participation, the expectation that continues to increase, that we are able to easily submit data and that we have interoperability as well. And so then the 21st century cures, people need to access their data in one place. So how do we get patients to be able to have a lot of trust and the ability to retrieve their data? So I think the HIE, you have to define what that means to your stakeholders. Is it truly the verb of just exchanging data, or is it a clinical repository and aggregation that we need to transform healthcare? We would argue both functions, both the verb and the noun, but really it's the latter that's going to move healthcare. The Pdmp is an opioid tool or a patient safety tool. We have really found that we have been able to significantly reduce our opioids across our system, and that would not have been possible without the Pdmp. Also very close ties to Medicaid and public health. I don't know, there's probably some among you that are working with Medicaid, and we have a lot of frustration in trying to get data in a timely basis. So we really feel like the HIE would be very helpful to take care of at-risk populations. And then, of course, COVID. Our HIE was able to put together very quickly a COVID dashboard, and we can see hourly now infections across the state, bed counts, PPE availability, ventilatory ability. And so we still have work to do around data definitions, but that was very quickly has been very helpful. And I've even heard the governor state that, without that dashboard, he was really just getting very fragmented responses as to our state of readiness. It really helps hospital provider needs, as you know. And then, the training and education, I don't want to, I think this gets minimized, but the better trained you are and the more you understand the HIE, the better suited you are to be able to use it optimally. And then meeting policy expectations for the consumer and patient access is a longitudinal record. That was the wonderful thing about the VA, is that you could get all the veterans data in a single source of truth, a true north. And so I think this is really what the HIE does for you. So this is just person-centered interoperability and reducing the burden of HIT. If we don't reduce the burden of HIT, we'll just continue to have more burnout and a lot more alienation of very well-trained folks in terms of trying to use this. So this should be a supporting tool. It shouldn't be agonizing and wanting to pull your hair out when you use it. And I think any practitioner will tell you, as they've tried to search for patient records, how irritating and really inefficient it really is. So 47% of healthcare payments in 2019 are tied to value-based care. And as you can see, that's up significantly. I spend a lot of my time working with value-based care, and it is so important that we have a very good eye into the post-acute setting. As many times, that's where the breakdown occurs and the readmissions come from, as well as a significant cost that we can really help support patients and improve quality while trying to really reduce those costs. And then, Ncqa will empower the healthcare communities through the steadfast pursuit of advanced interoperability. Anything we can do that wherever a patient seeks care, their data is right there and is available to whomever is treating them. And then bringing data democratization to consumers and providers. We've all been patients, and we've all been sons and daughters and have children of patients, and trying to get records is really a very frustrating endeavor, many times still in 2020. And so really cultivating economic value too. How do we empower our consumers and providers to realize the cost containment through benefits of our products, services, and innovations? Really, how does the HIE take on that type of expertise? I just want to, just support that. I think that the HIE, as it serves the health of the folks in your state, really being a cohesive model to move forward data. As you probably all do, I have multiple vendors every day who are wanting to give me solutions to many things that we've talked about today, all with a six-figure tag at least on them, and many that really are too narrow, or they don't work as well, or they're really, we can't afford them. It becomes an affordability issue as well. So I guess that's all my slides, and I'd entertain any questions at this time.
Dr. Polich, a couple of questions. We hear a lot about return on investment and is it worth it? In healthcare, technology implementations have historically been, difficult at best, sometimes even a little bit painful. And I'm curious what it's been like for Nebraska and what you've realized in terms of ROI.
So, I would say ROI for us at this time is very significant around patient safety. As we were talking about, you are able to now through our HIE see all the medications, and a lot of anecdotal feedback from clinicians about how they would not have known outside of the HIE that patients were on significant drugs that would have caused interactions. And then, of course, the amount of opioid complicated activity where patients are seeking multiple ERs and physicians. And so I think, one, there's a huge patient safety ROI. And then the second one that we've not totally realized what the cost is, but something we're very interested in, is really given a 360 review of your patient, you can really then represent the complexity of that patient. And that's really, I think, over time is going to give you a significant boost in your revenue, because you're able to really show that patient. And, whereas I think if you don't have that historical visits and all the different diagnoses, you're much less likely to have a CSI that's as high. So we have not, just from our own healthcare system, really put pen to paper, but what we're really looking to is in the post-acute space. Like I was talking earlier, we know that the cost of post-acute is significant. We're in these risk-bearing arrangements where we have to reduce that cost, and the HIE is helping us understand where those folks are, how long they stay, what kind of complications they have, and then we're really wrapping our services around that. So we think without an HIE, it would be very difficult to do value-based payments.
Dr. Polich, we have a question from a participant. It says, how did the Nebraska HIE reach NCQA certification, and what problems does that solve for payers and providers?
So I'm hoping Jamie Bland is on today. I really, I do not know the history of the NCQA, the process of how they submitted, except to know that given a governmental entity, it was very lengthy and complex, and they had to show their ability to get accurate data. So I think we could respond to that question. I can have Jamie send Kurt a summary of that.
That would be great. And then, Kurt, there's a second part to that question. Will Big Sky Care Connect be pursue the same path?
Great. Thanks, Kelly. Jeanette, can I turn that question over to you?
You can. I'm not sure that I have the answer, though.
Okay.
I believe that is in our plans for future enhancements, but I do see Jean on the line. Maybe she could answer that one.
Hi, everyone. Yes, this is Jean. Could you repeat the question again?
Jean, the question was whether we have in our plans for Big Sky Care Connect to reach out and get NCQA certification.
So that is a question that we are continuing to investigate, and that isn't in the current, I guess the current and the near future plans, but that is an ongoing discussion that we are having with ourselves and with our vendors as well.
Thanks, Jean. Thanks, Jeanette. Are there any other questions from the audience for Dr. Polich before she signs off? All right, not seeing any. Again, Dr. Polich, thank you so much for joining us today and sharing what you've learned by being a part of the HIE in Nebraska. And we wish you a pleasant afternoon.
You too. Thanks so much for having me. Goodbye now.
Bye-bye. All right, up next on our list, we have Chip Gore. I see he's on. Hi, Chip. Thanks for being here today.
Hopefully everyone can hear me and this part's working. This is always a fun process.
It always is. Yeah, we can hear you loud and clear. Thank you. So Chip is the senior sales engineer from Intersystems, and Intersystems will be the technology powering the health information exchange in Montana. And I believe that Chip has a bit of a demo to share with us so that we might be able to get a glimpse into what our HIE might look like once we launch in September.
Yeah, hi. Hopefully everyone's going to be able to see my screen. It won't look like it's a big sky thing, even though it's a picture of the galaxy. What I'd like to show real quickly and then sort of open it up for any questions about how the process would look like. As was indicated, Nebraska is using the same technology as you folks at Big Sky are using, which is the Intersystems Health Share platform. The Health Share platform is an HIE solution that provides identity management, the normalized longitudinal medical record. It takes content in from multiple data sources and then presents it in a clinician-friendly view, and then also is a normalized form for which all of the analytics for population health and cohort management and such are all available because we have the common data set underneath the covers. And I've been asked to sort of show just a quick view of what the clinical viewer looks like and how the health share framework actually looks like. The specifics of how Big Sky will do should be branded and color-coded and stylistically will match the Big Sky branding, as it were. So what I'm going to actually be showing is just the vanilla Intersystems version, which has only been tweaked to advertise in Intersystems and not Big Sky, but that's to be expected. It is a web-based interface that requires credentialing to sign in, and I'm actually just going to sign in as one of my pretend doctors here. What we're actually looking at and going to be looking at is completely synthetic data, so we're not looking at any real patient information, but it kind of shows what real patient information could look like in this environment. So if I go ahead and log in to the health share environment, and I get brought to what's referred to as the clinician landing page or search page, where from here I can get access to the secure messaging system. I can manage cohorts of people that I care about, the relationships that I've got, my favorite patients that I want to deal with, or I can actually just search for patients out in the environment itself. Now, I've got just a handful of synthetic patients in here to sort of show what this looks like. But if I interact and present what information I've got about a particular patient, then behind the scenes, we have what we refer to as an enterprise master patient indexing solution or an EMPI solution that will take the demographics and either do probabilistic matching to try to find the most likely match to who's there, or if you provide a specific identifier that's unique to your EMR or your assigning authority, as we call it internally, then we will actually do deterministic matching. If we've seen that patient before, then we know, oh, this is the person that you're actually talking about. In this case, I'm just going to go look for a vanilla John Smith to sort of show what this does. It comes back and shows me a whole bunch of possible Smiths that are available here that's gone and given me a listing on it, which for any one of these, I can see the specific content I've got behind them. Let me go back and be a little bit more specific and actually just look for, oops, if I can type. And look for John Smith. I get a smaller list in this case. And in case in this environment, I can say, oh, here's the John Smith I actually care about. He's my One Memorial Drive, which is where our corporate headquarters happen to be. And I can see that this John Smith actually has content that's been submitted to the exchange from 4 different, what we refer to as data source providers, where they be clinical care settings, or from the drug prescription drug monitoring program, or any other provider of connected content to the health information exchange. And then we have a quick iconographic view of what kind of content has been presented, whether this is encounter information, whether this is progress notes, whether it's meds. So you can very quickly see, oh, this is the patient I care about, and here's the information that's available from those different sources. If I wanted to, I could select any one particular source and say, just give me what the exchange is seen for this patient from that particular data source. But in this case, I'm actually going to select the master records. So it'll go and fetch the content for all of the data source providers for this particular patient. And then we'll get brought into what we refer to as a summary landing page. This will be configured to have what Big Sky has decided is the most appropriate 6 items to be the overview component. This is our default overview where we have the diagnostics, the current medications, lab results, any known allergies, the appropriate documents, and this is in reverse chronological order for each one of the components that might have more, like my lab results, where I have the most recent labs up on the display rather than all of them or any random order that actually tries to make the most clinically relevant. On the left over here, we actually have what we refer to as clinical domains broken down into what we refer to as a chart book, which is very similar to what a lot of clinicians will be having inside of their EMR environment, where they're essentially logical units of the longitudinal record. Because as you imagine, over time, as more and more data is gathered from different sites and more different sites actually connect up to the HIE, this can be a very extensive pile of information. It's very quick to come into what we refer to as information overload. So by organizing this, you can see very quickly, well, if I only care about what conditions they've got, I can pull up and see the conditions for this particular patient. If I want to go and find out what their labs are, I can go directly to the labs and see what's appropriate there, highlighting the ones that have got abnormal values on them. I can actually go and pull up and see what the reference values were used on that, and so on and so forth for this. So I have this ability to, in a single view, get an overview of what we know about the patient, as well as drill down into the specifics of what's important. All of this information has been filtered via consent. So the information that is presented has only been consented to the individual login for the person who's connected up. So if I'm a clinician, I'll see a different set of information, a more complete set but I might not see all of the financial information. If I'm an administrator, I might see the financials and not the clinical. So depending upon how the roles are set up for each individual login for the environment, that can filter what is available to be seen in this environment. We have also the idea of a golden record for the demographics that comes out of the master patient indexing. So if I've got later information than I might have in an EMR for a zip code or a new up-to-date phone number and such, all of that gets rolled together in the master patient indexing technology and is presented as the master demographics for the particular patient. I'll pause here real quick. Any questions on what people might be interested in delving in deeper, or anything in particular coming up in terms of questions on this? Because I can certainly drill down to the weeds if people care about it. Give people a chance. And since no one's, we have to go through the chatting process, I don't know. There's a chat message.
Is there claim data view as well?
I don't have claims data inside of this particular demonstration system I've got set up. Claims are treated as a separate clinical domain, which would have their own chart book tab over here to the left that would say, oh, here's the claims that have been submitted and matched up with this particular patient. Again, this particular presentation is aimed for a clinician at the point of care, where claims is not necessarily that important at the point of care, but it might be in that care setting for the administrators and such on. So the information can be brought in and is folded into the internal longitudinal medical record, and then it will be presented, and we're still negotiating with Big Sky what's the visual to look like for how the claims will be presented, but the mechanics for putting claims into the environment and brought forward is absolutely part of the environment. Yeah, in terms of who sets up the roles, part of this is being set up by the Big Sky folks saying, these are the roles that we think people will be having, and then as each consumer or participant, data sharing partner as we like to call them, goes through an onboarding process and says, these are the people that we want to be able to have sign-in access to the technology. They will then map to the particular roles associated with that particular login on it. And there's a whole entire give and take process to say, okay, I've got clinicians and then admins, and then I've got admin, smaller practices, it might be both admin and clinician, and make sure the roles that are granularly setting up what functionality you get mapped to the particular logins that are in place. So there will be a laundry list of roles available when you set up your users to get sign-in credentials for this.
Chip, this is
Yes.
Jeanette. I'll just add some more specificity to what we're doing in Big Sky. We are setting up different user roles. We have 2 clinician roles that we've set up. The first will be able to access sensitive data, which is defined as 42-part CFR data and HIV data. And then we will have a clinician role that does not have access to that sensitive data. We also have a role set up for a front desk person that can get into the patient record but cannot see clinical data. We have a role set up for payers that allows them to only access the records of members where they are actively eligible with that payer company. And we also have a privacy officer that allows different organizations the ability to audit and monitor their usage within their organizations. We give those individuals access to audit logs.
Hopefully that answers Paul's question. In terms of medications, we consider the medications to be a specific clinical domain, and depending upon how the information comes in, it will get filed into the medications tab itself. And we actually have what is currently as submitted to the exchange. These are the prescriptions or scripts that are currently active for this particular patient. And then if I actually had a Pdmp environment here, then the medication history would also have all of that information that had been ingested from that environment linked to this particular patient in space. So hopefully, like I said, medications are here as part of the overall, like I said, a specific domain inside the environment. question about showing what's important. One of the things I didn't flag too much, if something is data that's been presented that has anomalous flags appropriately set up in the data, whether it's a lab result or whether it's a particular allergies are treated as a specific domain as our labs. But if something comes in that is marked as abnormal or out of range on it, then we actually go through a visual highlighting construct on it. In this case, you'll see I've got some labs that are out of whack, so they actually come up and will get highlighted in this, by default, they're highlighted as red. Some of our clients have actually chose to put little asterisks or flashing stars on. It depends on the specific visual language that's chosen to be used. This red one tends to be the visually impaired approved. I can't remember the acronym for what that called. It's good for people who are colorblind and such. You can actually still spot that. In terms of allergies, they have the same thing. If you've got a severe allergy, then that would also get flagged as in part of the allergy component, as well as allergies themselves having their own domain that's displayable on this. That's one of the questions we got here. In terms of, I wasn't planning on showing because I don't have an EMR set up here. In terms of showing how data is imported into an EMR, that's a real loaded question, presupposes how the data sharing relationship is going to end up being. Typically, there are two camps in terms of how data sharing partners connect up to the health share product. One of them is they will provide a single sign-on connection point from the EMR to say, it's this clinician or this login looking at this particular patient. Please show me what the exchange knows about them. In which case, the viewer is frequently just embedded, particularly if you've got, say, for example, an Epic site. The technology they use is what they refer to as a hyperspace window, which pops up a frame that then has the context of the particular patient and that record actually brought up for them. Then the other camp is when someone will actually take and ingest the information known in the exchange into the EMR's record itself, so it becomes local to the EMR, and then they have access to that information without having to go back to the exchange. That's a heavier uplift in terms of connections. We've got people that are doing that. It becomes a challenge based on the specific versions of the EMR you've got, whether or not you want to have data that wasn't put in by your clinicians into your permanent data record. So there's some legalese that has to go through in those data sharing agreements. I'm not sure if Big Sky has engaged at that level yet in terms of how this content becomes available to the clinician in their EMR setting. Like I said, most of the easy uplift ones is they will do a single sign-on launch of the clinical viewer from the EMR, but we can actually push information to the EMR depending upon how the EMR itself can accept information pushed to it. We have the ability to basically talk any of the healthcare standards in terms of formatting the longitudinal record into what is ingestible by the EMR itself. Hopefully that answers the question.
Yes, Chip, all those different methods we are supporting at Big Sky. So we have the direct access into the web portal, we have the single sign-on technology, and then we have the ability to do the queries to pull in the data right into your EMR. And in terms of sending data into the HIE, we support all versions 2 and 3 of HL7. We can also take in CCDAs, and we have other methods if your EMR technology is not able to support that. So, and all of those options are reviewed during the technical onboarding process. There was one other question about, can you show them how you can generate a CCDA from this system, Chip?
I can certainly do that. Why don't we go back out? I don't know if this guy's CCDA is very nice. Let me go back to pull up a different one. Let me pull up Marla's record here. Marla's a test patient we've actually been killing at Intersystems forever. She's got more interesting ones. Where's my export here? If I actually access the summary accessing the summary information here, then I have the, I still have people all over the controls. This is an HTML version of this, but I have lots of different formats that are available from, say, if I wanted a consolidated CCDA, this will actually generate this and allows me to then create a downloadable version of it. I don't want to actually download it. Where this is the actual consolidated CCD or CCDA document that is based on Marla's record that's all been put together, that then I can from here connect up to and find who I wanted to actually send the information to, and find the clinician I want to send it to. If they've got direct connection, then this will actually package up that along with any other notation that I'd want to. Just send it to myself here. Send it to Sam. And I can add, look. Here it is, just typical email sort of thing. And then I can say what type of, why I'm sending this to them. And actually can, if I choose to, I can filter down what is important to be included this, whether it's the entire thing or just specific encounters or specific data points within it. So I can not only say, send the entire longitudinal record, which over time can get very large, or I can drill it down to a much smaller set and then send it either via direct through the secure messaging framework to the specific clinician or the specific organization. And then the health machine then deals with all the logistics of getting that securely delivered and receivable by who that was actually sent to. Hopefully that answered the question.
And there was also a question back on the main profile. I do know that every data type that comes in is associated with a facility, so you can always see where the source of the data is. I don't think that you can see that on this main page, but then if you click on the item and drill down, you can see the facility associated with each of the data elements.
Yeah, with this her data is not real clear here. So if I actually look at a particular item, in this, I drilled into one particular lab result, just a synthetic lab result that would actually show, the hospital where it came from and the codes associated with it. That information is retained. In fact, when you get to the population health view of things and what we refer to as the health insight presentation side of things, that information, so we know where everything came from. It becomes a case of balancing real estate on the presentation to the actual data that's being shown. And again, the more data you get, the more easy it is to overload and overwhelm the display where you can't find anything you're looking for that's of interest. But yes, we have that information available, and the specifics of whether or not to show the source at the higher level or at the summary level is a configuration choice that we're still tweaking as we get feedback. That's something that can be changed downstream if Big Sky decides that more people would like to actually see that information available.
That sounds great. Thanks, Chip. Appreciate that. And we really appreciate you being here today and providing us some real life demo of what our HIE will look like eventually as we think about going live in just a few short weeks. If you do have more questions for Chip, I would encourage you to add those to the chat, and hopefully we'll have a little bit of time when we're done today before we wrap up to address some of those questions. I do want to move on to Rachel Lieber, General Manager at Collective Medical. I see that you're on. Hi, how are you doing today?
I'm doing well. Thank you very much. Thanks for having me.
Yeah, thanks for being here, Rachel. I really appreciate it. So it looks like the share screen is off and you're able to get yours up there and done. So I'm just going to go ahead and turn it over to you to talk about Collective Medical and give us a quick demonstration of what that technology will provide us.
Absolutely. So as mentioned, I am with Collective Medical. I'm really here to focus on the ED coordination project component of this overall launch of the HIE platform. I've worked with Intersystems actually for a really long time. I came out of Providence and we had an HIE using Intersystems, so I'm excited to work with the Intersystems team again. I think it really is kind of a best-in-class community health platform. And a lot of the themes that you just heard around the community health platform are similar technology solutions and systems that are going to be supported through the ED coordination piece. Collective Medical brings to the emergency rooms around Montana the ED coordination solution. And this is really going to be bringing encounter information out to the emergency room providers at the point of care in their EMRs, so they can really focus on reductions in inappropriate use of the emergency room and care coordination with all of you that will be using the Intersystems HIE. Just for the sake of time, I really am going to go quite quickly through this, and I want to really focus on the clinician experience from the ED provider role. So a lot of what you just heard from Intersystems is going to be really, really important to your outpatient care coordinators, your social workers, your health plan utilization coordinators. We work with organizations like that as well, but today I'm going to really just focus on the ED provider experience, which is deployed all across the Pacific Northwest. I have the pleasure of being the general manager for the upper left, as I like to call it, network of Collective Medical, which is inclusive of Oregon, Washington, Alaska, Idaho, and Montana. We have all of the hospitals in many of those states, as well as hundreds of others across the United States that share ADT network information with us, which we will also be sharing reciprocally with the Intersystems platform and Big Sky Care Connect subscriber. So the point of the ED optimization workflow is to really bring encounter information about patients to the point of care in the emergency room setting. There's a lot of how did we all get here and how did this data flow, but I really just want to focus on kind of what this is going to look like and feel like for the ED doc. So what I brought up on the screen is our example of an electronic health record. As patients arrive into the emergency room setting, they're usually greeted by a triage person, staff person, or a HUC who's going to ask them for some basic demographic information. First name, last name, date of birth, chief complaint, why are you here today? Maybe a social security number, phone number, address. All of that information gets entered directly into the hospital's electronic health record. Regardless, Epic, Cerner, Meditech, T Solutions, we work with hundreds of EMRs. And that data, either from Big Sky Care Connect's Intersystems platform or directly from the hospital EHR, sends a message to Collective Medical. Hey, do you know anything important about this individual that we need to be aware of? Jack says that he's here today for chest pain, but are there other things we might need to just be aware of as we're doing our initial intake and assessment? So I've checked Jack into the hospital today, and right here, as I've checked him in for chest pain, it flagged that there actually is an ED notification summary to review. The goal here is to provide the ED physicians with about a 30 to 60 second summary synopsis report about the patient they are about to meet, maybe for the first time, maybe not for the first time, and make sure that we're just aware of a couple of other high-risk characteristics about that individual, which might need to come into play as they just evaluate for chest pain. And I'm going to go through those. We call this an Eddy notification. Through the ED coordination project with Big Sky Care Connect, this can either be delivered directly into the EHR, or our hospital partners can choose to have it faxed as a piece of paper. We will support either depending on their workflow and what makes the right operational fit for the nurses and physicians in the emergency room setting. But once I go ahead and arrive that patient into the EMR, within about 10 seconds, this Eddy report summary is going to be populated right again inside of that Epic trackboard or Cerner trackboard, or faxed to the nurse's station in the emergency room for review before the emergency room provider actually makes their first introduction. And that's really important. This is intended to really help the ED provider have a really comprehensive first impression as they do their initial intake assessment and plan. This is what an Eddy report includes. Right up at the top, we're very focused at Collective Medical on supporting safety of clinical staff. So if this patient has a documented security event in our system for a variety of behaviors or situations like assaultive language towards emergency room staff, let's say that occurred in Providence Sacred Heart in Spokane, and they've now arrived in Helena. that information would be at the top of the report to just make sure that we understand some other ways to approach this patient to mitigate potentially causing another unfortunate situation and protecting our healthcare workers, really driving up that staff satisfaction. Once we get through the security and safety event section, we're going to get into the case management notes, or what we call care insights. These are short, specific, succinct suggestions from that outpatient community on the collective network, suggesting some ways to approach the patient or provide some care recommendations if they have chronic conditions that the outpatient folks or health plan folks are working on with the patient. This could be the patient's sister or mother that should be there with the patient at time of intake assessment and evaluation. In addition is what we like to refer to as our encounter history. This is a 6-month look back inside of the summary of places in which the patient has been arrived in an emergency room or urgent care setting shared on the network, or a skilled nursing facility on our network. The location in which they were arrived, the type of visit, inpatient, ED, or observation, and then an aggregated summary of chief complaint, admitting diagnosis, and discharge diagnosis. And then what was their discharge disposition? So this individual had acute dystopic congestive heart failure, and at the end of that visit, they were discharged to SNF. And that just happened maybe a couple of months ago. We need to keep that involved in our diagnosis of chest pain for which they're here today. We also give a summarized quantitative list of the facilities in which the patient has visited one or more times. And this often identifies for the ED provider at the point of care if there might be an emergency room medical home for this patient. Some of our patients that we interact with are actually served well through emergency room settings, just for relationships or lack of secure housing, or just establishing care in the community in which they've moved. And sometimes the ED provider says, well, this is the first time that I've met them, but it looks like they have a trusting relationship with another facility. I might want to talk to them about what they also know, in addition to their assigned case manager. Moving down, you heard a lot about prescription drug monitoring and Pdmp. We complement that encounter history with also an integration to state databases for Pdmp. We have this in some of our states that we work with, like Oregon and Washington and Alaska, some friends of all of yours. And this can draw in type, class, prescriber, count, and date, and prescriptions that have been filled and reported to the state Pdmp. And then finally, other members of the care team that the ED provider at the point of care might want to be aware of. I've kept this demo really focused on the ED physician workflow, just to make sure that we get through that ED role today. I will say that this also is complemented by an ED case management workflow that allows for that referral of a patient in the emergency room setting to be warmly handed off to ED case management for maybe more of a broad assessment of social determinants of health, behavioral health conditions, getting a referral to substance use treatment out in the community, or other things that the ED case management team is so good at to make sure that this patient is warmly handed back to the organization that really is going to maintain that longitudinal relationship with them. So I know I went through that really fast, but this is what we're going to be working on across all of the emergency rooms in Montana in partnership with the Intersystems team and Big Sky Care Connect. We're very excited to get started soon, and I hope that that's enough of kind of a look and feel for today, and I'm happy to take any questions.
Excellent, Rachel. Thank you. That was fantastic. So questions for Rachel regarding ED notifications and the technology behind all of that and what that will look like for Montana's Health Information Exchange. Not seeing any questions coming in right away. So you must have done a great job quickly going through that. But I just want to take this opportunity of a pause to thank you, Chip and Rachel, again for attending, for sharing some knowledge with all of the providers that were in attendance today, and taking time out of your day or lunch hour to be here with us. So thank you so much.
Hopefully it was helpful.
Looks like we do have a question that's come in our chat. Will CMT receive the ADT feeds from Big Sky Care Connect, or will 2 ADT feeds be created for each hospital, one for Big Sky Care Connect and CMT?
Great question, Michael, and always nice to see a familiar name and face. We go way back for our work in Oregon and also Idaho. So Collective Medical and Big Sky Care Connect, yes, are working on setting up reciprocal ADT interfaces so that that Big Sky Care Connect community can get the benefit of lots of data we have about Montana folks. And we can also add information that Big Sky Care Connect is going to garner about their new subscribers into the collective community. So we're working on those interfaces today. And then, let's see, did I get the other question? Let's see, how can we access the part of this webinar series? I don't know if that one's for me.
I think that's more for us, and it looks like Kelly answered that in the chat. Yeah, we are going to have this webinar and the first in our series both available shortly, and those links to those webinars are going to be sent out to anyone who is registered for either of these webinars, and you'll be able to view or even share links to those recorded webinars once we get those sent out. Well, I'll just conclude by thanking all of you for attending today. We really appreciate it. I would like to remind you that if you do have follow-up questions or if you want to reach out to any of us at Big Sky Care Connect, please do so. We can be reached. I'll just go ahead and put up our contact information for you. And we can be reached here at our website at mtbscc.org, our telephone number, or by emailing bscc@mmaoffice.org. I want to thank everybody for attending and wish you a wonderful afternoon. And please look forward to future webinars and information coming from Big Sky Care Connect. I hope you all have a great afternoon.